Alright, so the whole point, just like I explained just a minute ago, the whole point in us going through the A&P is to have a refresher on the anatomy and physiology, and then to look deeper into the electrophysiology and to understand what's going on with the electrophysiology and what area of the heart is being affected. Because that's going to be very important whenever we get into dysrhythmias. Because depending on what the dysrhythmia is, that's going to give you a lot of information as to what part of the heart is affected. Now, do know that, and we'll talk about this more when we get to that point, but an ECG recording is just an electrical representation of the heart. It's just showing us the electrical system. So the heart is actually two systems, right? The heart has it functions off of two systems. It functions off the electrical system and it functions off the mechanical system, right? So the electrical system is going to be your pacemaker cells, your electrical conductor cells, the ones that have those 4 specific properties, and then your mechanical is going to be your myocardial cells, your worker cells, right? So when we look at an ECG, we're just seeing what the electrical system's doing. We don't really have any way of gauging on the ECG monitor of what the mechanical system's doing. What's going to be your best assessment tool to look how the mechanical part of the heart's working? What? Yeah. Looking at your hemodynamics, looking at your blood pressure, looking at your pulse, looking at your basic assessment, your appearance, things like that. Now, of course, when they get into the hospital, they can do echocardiograms and ultrasounds of the heart and look at that and look at the valves and all that. But we're really learning in this class, we're learning how to read those ECG monitor tracings, and we're also going to be learning how to do a good paramedic assessment, cardiac assessment. So all of our assessment stuff is going to be geared straight towards cardiac-specific diseases and things like that as we move forward. All these are our competencies, education standards that are part of the paramedic education standards that you will need to come out of this class knowing. You can go back and look at those. So going back in the history of paramedicine, where was the first official paramedic unit established? Sure about that? Los Angeles, California. Yeah. Most of us have had to watch it on Netflix, but Johnny and Roy, emergency. Los Angeles Fire Department, Rampart, all that. Why was this established? Like, what was one of the main goals of this? Because they have folks dying of heart attacks left and right with no real pre-hospital care. So they established this EMS system with cardiac care as one of the mainstays in mind. Even to this day, cardiac care is really the paramedic specialty. Cardiology and trauma, right? Most paramedics in the field don't know nothing about birthing no babies, right? You birthed a baby? Did it hurt? You had a quick recovery time. Just kidding about that, but really our area of specialty, you know, one of the main areas that we look at is ACLS, cardiac care. You know, go to any experienced field medic right now, and they're going to know those American Heart Association algorithms left and right, backwards and forwards. All right? They're going to know their cardiac drugs left, right, backwards and forwards. They're going to know their dosages. But one thing they may not really remember is why we give those medications, or why we do this, why we do that. And so really that's what we're going to be trying to tell you is why are we giving this stuff, so that you'll understand a little bit better when you actually get out in the field and do it. So The heart really interests me a lot. It's my favorite subject to teach because it really is just interesting, and it really is one of the mainstays in EMS. There's so many advancements that have been happening with pre-hospital cardiac arrest management and pre-hospital just cardiac management, cardiac disease process management. And so it's only going to go farther as EMS continues to progress in the field. But one of the main reasons why it is such a mainstay in EMS is because heart disease is the #1 killer in America. But is somebody going to be stricken with a clot in the coronary, the big one, a heart attack, while they're sitting in the middle of the emergency room, or while they're at the hospital, or while they're at the doctor's office? No. I mean, every now and then they might luck up and get to the doctor's office in time. But primarily, it's going to be an acute onset, and we're going to be the ones taken care of, right? Right after the Big Mac. So heart disease kills approximately 600,000 Americans each year, and probably 3/4 of that are going to be acute in onset, with us making first contact with them. The first 5 minutes or so are going to be the most crucial, right? With cardiac care, especially with cardiac arrest and ACS, those first 5 minutes is really what's going to be the deciding factor. Everything with ACLS, everything with advanced cardiology is going to come back to the chain of survival. Y'all remember that from CPR class, where you even got into EMT school? The chain of survival. With #1 being what? Early recognition. #2 being what? Early CPR, then activation and AED use, and then ALS. So ALS falls way at the end of the chain of survival, right? And then you got definitive care. So we're going to learn the ALS in here, but it's always going to go back to good CPR, to good basic management, because quite honestly, I can teach you how to interpret a rhythm all day. I can teach you how to shock a rhythm all day. I can teach you what medications to give all day, but if you give a medication and you're not circulating that medication, you ain't doing them a hill of beans, right? Your critical thinking skills that hopefully you started to develop in advanced EMT are going to really come into play now, because you're going to be it. You're going to be the primary gal or guy out there making these decisions and needing to move quickly. Risk factors for heart disease, stuff that you went over before. I don't think I need to hit all of that. Other than the fact that America is a pretty lazy and entitled country that doesn't really like to do a whole lot, and so that's why there's so much of this. We've got fast food just readily available. We've got harmful substances just readily available, you know, and so we've got Xbox and Warcraft World or whatever, just where we can just sit and play all day long, just readily available. And so all this stuff's going to contribute. Now you do have those non-modifiable things such as family history, genetics, type A personality traits. I think that's just because you just stress your heart out like crazy. You're very much risk takers, you're very much extroverted, things like that. Usually, a very large portion of folks in EMS are going to be type A personality types. And a very large portion of folks in EMS are going to eat McDonald's or Zaxby's every day. And a very large portion of EMS is going to use tobacco or smoking products every day. So, you know, we got to make some changes if we're ever going to be community role models, that's for sure. With all the new changes coming about with the health insurance and reimbursement, with the Affordable Care Act and things like that, you're going to see your role as a paramedic changing a little bit. Now, you're always going to have those acute issues, and you're always going to have the traumas and things like that. But you're going to start seeing, you can mark my words, within the next several years, you're going to start seeing a lot more a bigger presence of EMS in the community, doing awareness, doing teaching, doing follow-up, doing home visits. Yeah, doing all that kind of stuff. Making transport decisions that, to this point, you're not allowed to make. If somebody calls 911, you have to take them. It's coming where triage systems are coming. Because of the reimbursement stuff, a lot of stuff that has to do with heart disease or cardiovascular disease, which isn't just ACS, isn't just heart attacks, it encompasses congestive heart failure, peripheral vascular disease, coronary artery disease, all this stuff. There's, for lack of a better word, a pissing match between Medicare and Medicaid and the hospitals, or really Medicare and the hospitals, that's saying, hey, these people with these chronic illnesses, they come to the hospital once, we're going to pay for them, but if they show back up within the next month because they're being poorly managed, we're not paying for it. The ambulance isn't getting paid, the hospital isn't getting paid. So you start seeing companies getting their paychecks withheld and all that kind of stuff, you're going to start seeing your presence being a lot more in the community, trying to keep these people from utilizing the system when they don't really need it. All right. So just be prepared for that. Even within this time that you're in medic school over the next year, we may see some big changes. You know, I don't know. I'm not going to spend a ton of time on the actual anatomy and physiology of the heart, other than just refamiliarizing you with where everything is, okay? Because if you have my class, I know that you got a good A&P of the heart, and if you've already had the other stuff, you should have at least had a good A&P, but we are going to refamiliarize. So your cardiovascular system is a closed system, right? Composed of the heart and the blood vessels. Composed of the pump and the interstate, or the transport system, right? Delivers oxygenated blood and nutrients to the cell. Goes all into that internal respiration, external respiration stuff that I pounded into folks' head. And then, of course, does your waste disposal. What happens when you bring technology into the classroom. Alright, so the heart. Everybody take your fist. Everybody take your fist. Everybody take your fist and close it. Look at it. That's about the size of your heart. Alright, take your fist. Bring it to your chest and turn it just a little bit to where your thumb's kind of, for me, is kind of at an angle. Put it kind of right there. That's where your heart is. Okay? Top of your heart, what's it called? Alright? Base and apex. So it's kind of backwards, right? Because usually the base is going to be the bottom and the apex is going to be at the top. It's geography. Is that right? Not geography, geometry term that they use. So the reason why it's called that is because if you can imagine the heart kind of in the shape of a triangle, the point is the apex and the bottom is the base. So if you can imagine your heart kind of as an upside down triangle, the apex is going to be at the bottom and the base is going to be at the top. Okay? Having fun yet? So, it's the size of the fist. It circulates 7,000 to 9,000 liters of blood a day. It's a lot of blood. How much blood does the average human being have? 4 to 5 liters of blood. So your complete amount of blood is circulated a lot throughout the day. Even in 1 minute, your cardiac output is usually the amount of blood that you've got in your body. Your heart is probably going to be the hardest working organ in your body, because it never stops, right? And so that's why it is so susceptible to illness when it has a lack of oxygen. To really remember the way that the heart works, we need to talk about the blood flow through the heart, right? Yeah, we do. So, starting with the right side, what brings the heart into the right atrium? The vena cava, the superior and the inferior vena cava, right? Brings it into the right atria. From the right atria, it goes through what valve? Tricuspid. Try to do right. Try to do right. It goes through the tricuspid valve into the right ventricle. From the right ventricle, it goes through what valve? Into the pulmonary, through the pulmonic valve, because it's going into the pulmonic system, or the pulmonary system, right? Which pulmonary vessel does it go into? What am I about to ask? What am I about to ask about the pulmonary artery? It's the only artery in the adult human body that carries the oxygenated blood. But really and truly, that does matter to understand that. But one thing is constant about all arteries. They carry blood away from the heart, right? So the pulmonary artery is going to carry that deoxygenated blood. Why is that blood deoxygenated? Y'all heard me. Why is that blood deoxygenated? And that's a very smart aleck answer. They're bolicious. Right, the body's already utilized that blood, and so the right side is pumping it back so that it can fuel back up, right? So it's going to go into the pulmonary artery, into the lungs, where what's going to happen? What type of respiration? External respiration, right? The offloading of and the onloading of oxygen. So from the lungs, it's going to go back through which vessel?
Pulmonary vein.
Pulmonary vein into the... So is there only one pulmonary vein? There's several. I think there's 4 pulmonary veins that feed that left atria, bringing blood from all areas of the heart. So the left atria goes through which valve? The mitral. The mitral. I always remember mitral because it has the L at the end of it and it's on the left side. There's another way that I'm going to show you in just a minute. So, through the mitral valve into the left ventricle. From the left ventricle through which valve? The aortic. Into the aorta, into the rest of the body, right? So, with your valves, you've got cuspid valves and you've got semilunar valves, right? Your semilunar valves, they're called semilunar because they kind of look like a half moon. I might have just made that up, but y'all would have never known the difference. They do kind of look like a half moon and they close in together. The tricuspid has valves that are attached with chordae tendineae, the little strands that hold it together, and it has 3 flaps. And then the bicuspid only has 2 flaps. All right. So what's the point in the valves? Keep backflow, or to prevent backflow. So you've got your layers. You've got your epicardium, your myocardium, and your endocardium. If something happens to these layers, that could cause some issues for the heart. What's the traumatic thing that can happen in these? Tamponade. Tamponade. You get that fluid in between these layers. So your epi is the outmost layer, and your endo is inside. It's the closest layer. All of them are very, very thin layers. A couple things to remember about your right and your left ventricle. So your right ventricle, it only has to pump blood against a very low pressure gradient. It only has to pump blood through the PA pressures, the pulmonary arterial pressures. Alright, so they're usually pretty low, meaning like 30s over teens, alright, millimeters of mercury, compared to the rest of the body's blood pressure. So the right ventricle does not have to be as muscular, right? So it's always going to be a little bit thinner. The ventricles are separated by the interventricular septum, and then you got the left ventricle, which is a lot more muscular. Why? Because it has to pump against what? Did you say it? Yes, the systemic vascular resistance. Also can go hand in hand with what term? Afterload. 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 Alright? So the left ventricle has to pump against the systemic vascular resistance, which is really just the amount of pressure in the peripheral vessels that the left ventricle has to overcome in order to get the pressure out. So it's a pressure gradient. It has to create a higher pressure than the pressure it's forced up against. Does that make sense? Yes, it makes sense. You got your pericardium, which goes hand in hand with your layers. And so this is really where you're going to see the effects of the pericardial tamponade, which is going to be a large accumulation of fluid, or your pericardial effusion, which is a small amount. Now, just because you guys are super smart, what is that law that pericardial tamponade would affect? What? Old Frank Starling, right? Old pericardial tamponade, it just puts a damper on Frank Starling's law. What was Frank Starling's law? And it's actually 2 different people, but I don't know their first name, so I like Frank Starling. The greater the stretch, the greater the force out, right? And that's really just common sense. If you blow a balloon up to its max pressure, that pressure is going to come out really quick, right? And that thing's going to go all over the place. If you only blow the balloon up just a little bit and that elastic just stretches just a little bit, the force isn't going to be as much coming out. Alright? Y'all remembering this stuff? You seen this? You heard about this? Yeah, you have. That's why I'm proud to be your teacher. Alright, so your coronary arteries. Coronary arteries are probably the most important arteries in the body. Because if they're not doing their job, then it doesn't matter, because the heart's going to shut down and none of the other arteries in the body are going to get what they need. So the rest of the body really depends on that pump function of the heart, right? So whenever blood is oxygenated, the heart's going to get its tithe. It's going to get its first fruit. It's going to get its 10%. Praise the Lord. Right? It's going to get the first stuff that comes out because it has to. It has to stay continually oxygenated. So your coronary arteries are going to be what supplies the heart, right? Then you've got your coronary veins that take that deoxygenated blood back. Every minute, the coronaries deliver 2 to 250 milliliters of blood to the myocardium during rest. So they're really the only arteries that are working during diastole. Because during systole, the aortic valve is opened up and the blood is rushing out to the rest of the body. During diastole, the coronary valves are opened up and the blood is getting infused into the heart. Have y'all ever heard the term the widowmaker? Not referring to old cowboy movies or anything like that. Yeah, it's the left. It's a left anterior descending artery, which really bifurcates and breaks off into all several other different circumflex and posterior arteries and all that. But the left coronary artery supplies 85% of the blood supply to the myocardium. So it's kind of like, why didn't it just pick up the other 15% and let the right coronary stay at home? So that's why it's called the widowmaker. Because depending on where a clot is, if you have acute coronary syndrome, depending if it's a real high clot that's going to cut off circulation to 85% of the heart, you ain't going to last no time, right? You remember me talking, or those of you that's had events, do you remember the term I used, collateral flow? Like if it's a small area of the heart that has a clot in it, usually it can pick up and at least feed around it so that the heart still has time to be seen about. You wouldn't have that if you had a left coronary high up, like in the stem of it, because 85% of the blood is being supplied to the heart. And then the right coronary carries the rest of it. So your coronary arteries, they begin just above the aortic valve where the aorta exits the heart. So kind of imagine this is your coronaries here. Here's your aorta. So the coronary valves are going to be down in this area right here, and then they're going to open during diastole, and they're going to fill the myocardial cells. You having fun yet? At least there's no liars in here. So the left coronary artery, it supplies all that you see there and part of the right ventricle. Right coronary, the right side, and a little part of the left ventricle. So, if you see here, the left coronary is and the circumflex, which is off of the left coronary, it's going to reach around to the back of the heart. And it's going to supply a large portion of it, whereas your right is really just supplying this part and part of the left ventricle, not much. All right? And again, it's important. It's important because they are your lifeline for your heart. Your heart has to stay oxygenated. Here's a pretty cool picture. That's just the vessels. Look how big these coronaries are. I mean, of course it's enlarged, but you know, if you can imagine, if you've got a clot big enough it's going to clot up right there, look at all the area that it feeds. Pretty big deal. That's why ACS management is so important. I think we went through this pretty good. Get to the pumps real quick, or in just a minute. So you've got, in order to feed the myocardium, you've got your arterioles, right, and your capillaries, which are your microscopic blood vessels that's going to do all your oxygen onloading, offloading, and your gas exchange. The coronary sulcus is a groove on the heart separating the atria from the ventricles. It's kind of hard to see here. Yeah, it's pretty hard to see on that one. Then your venous blood empties into the coronary sinus, which will bring it back into the right atria. The AV valves, your cuspid valves, your tricuspid, and your mitral valve, which I know that we just talked about, so I'm not going to spend a lot of time on it. Ah, dropped my heart. My heart sank. Got a broken heart. I can go all night, guys. Alright. So, this is going to have your cuspid valve. It's on the right side, so which valve is it? Your tricuspid, so it's going to try to do right. Alright? This is going to be the left side, and it's going to be the mitral valve, and then you've got your aortic valve, your pulmonary valve, pulmonic valve right here, and then you would have your aortic valve right here at the aorta. I got a couple of these little hearts that y'all can pick up and kind of look at and refamiliarize yourself with them and all that if you want. And so your pulmonary and your aortic are your semilunar valves. I think we've talked a good bit about these. Don't think we really need to spend more time on that. Here we go. So this is a good way to remember the blood flow of your cardiac valves. Tissue paper, my assets. Tricuspid, pulmonic, mitral, and aortic. And that's the way it is in order. So remember that. Tissue paper, my assets. You see, must be Auburn fans because they're rolling the heart. Quickly into the cardiac cycle. Remember, diastole is the chambers at rest. Systole is the chambers at work or at contraction, right? Don't have to do a whole lot of that. So this is where it's going to be important to understand where filling happens, or when filling happens in the heart. Because there's going to be a new term I'm about to tell you that you probably already see that you probably haven't heard before. So during the relaxation phase or diastole, the left atrium fills with blood under venous pressure. So then it's going to squeeze down into the ventricle, all right? And what causes that? What causes that contraction, that atrial contraction? The electrical system. The electrical system. So it's going to depolarize, the atria is going to depolarize, and then it's going to push the blood through the mitral and the tricuspid and the mitral valves, and then it's going to fill the ventricles. But then the ventricle is probably only going to get, between 60 to 70% of the blood from the atria. Then the atria will have another quick pump called the atrial kick, which it accounts for about 10 to 40% of the rest of the ventricular filling. So it's going to allow for ventricular filling, and then it's going to have that atrial kick to where it's going to push the rest of it in. So that's a new term you may see on a test. The atrial kick. Kick. All right. So we just kind of went through the blood flow through the heart, so I don't think we really need to go through this again. do want to talk about the pumps real quick. So the heart is a pump, but the heart is actually two pumps, right? You've got a low pressure pump, which is on the right side, and then you've got a high pressure pump, which is on the
left side.
Why is the right side a lower pressure pump? Because of the pressure gradient that's in the pulmonary artery isn't as high as the pressure gradient that's in the rest of the body that the left ventricle has to overcome. Think we're good with the blood flow through the heart. How about y'all? Y'all good with that? Just refamiliarize, preload. Preload is going to be the initial stretching of cardiac myocytes prior to the left side contraction. And that's really the technical definition. But what have I always told you preload was? It's going to be the amount of blood that the left ventricle has to work with that's coming back to the heart. It's also can be, well, I'll get to that in just a minute. And then your afterload was the amount of pressure that, or the amount of blood that's coming out and the amount of pressure that's coming out of the arteries. Now, afterload isn't specific to the left ventricle, all right, because the right ventricle has to overcome pressure too, all right, but the afterload pressures of the left ventricle and the right ventricle are going to be different because of the pressure system. All right, does that make sense to you guys? All right, good. I'm telling you now, if I'm already losing you, it's going to be a long semester, okay? So most of you know me in here. For the ones that haven't had me before, you know that I'm willing to help you out if you will just stick with me and follow me through, okay? You got your two circulations, your systemic circulation and your pulmonary circulation. So your pulmonary circulation is going to be in itself its own unit of circulation. You got your pulmonary artery and your pulmonary vein, which are there to accomplish one purpose and one purpose only, and that is to get deoxygenated blood away from the heart and oxygenated blood back to the heart. All right? And then your systemic is for one purpose and one purpose only, and that's to get deoxygenated blood from the peripheral system back to the heart and oxygenated blood back to the system, to the cells. Okay? We talked about the capillaries and the venules and all that stuff. That's where your gas exchange is going to occur in the lungs. Really don't think I need to go much deeper into any of that. I'm not going to go deep into these blood vessels. Y'all can look at them. You've got your three layers. Important as we get on into this is that your vessels are controlled by the nervous system for the most part. And then there's medications that you're going to see in this class that will affect your vessels. You know about arteries. You know about veins. All your blood vessels. Which one's your major artery? Your aorta. Then you've got your vena cava, right? Aorta's under high pressure. Bad news if it ruptures. Somebody tell me what time it is.
10:10.
What?
10:10.
10:10. Just some technical terms we need to go back and look at. Cardiac output is going to be the amount of blood pumped by either ventricle in what unit of time? Cardiac output, 1 minute. Stroke volume is going to be the amount that's pumped out by either ventricle in what unit of time? One contraction. All right, I guess that's not really a unit of time, but every contraction is your stroke volume. So before well, it's on your paper, so I'm not even going to waste time. Your heart rate, we know what that is. Your ejection fraction, that's going to be the amount of blood that's leaving the heart on each contraction from the ventricle. Does the ventricle, would you ever, even in the most healthy person, would you ever have an ejection fraction of 100%? No. Your average ejection fraction is really going to only approach about 75% for the most fit, healthy people. Why doesn't the ventricle pump every last ounce of blood to the body? Yeah, I mean, it's a hollow, pliable chamber, so if it didn't leave a little bit in it, it's going to collapse in on itself. That's at least the best I can figure as to why it would do it. Going back to stroke volume, your normal stroke volume is 6 to 100 milliliters. That's per pump. Your healthy heart can increase the stroke volume by at least 50%. Why would stroke volume and cardiac output need to be increased? Yeah. Higher demand for oxygen. So if you're exercising or doing something strenuous, the intrinsic properties of the heart is to increase heart rate, increase stroke volume, which is going to increase cardiac output, right? Because the cells in the body are going to demand a higher amount of oxygen. And this was your equation. You'll see this again. Cardiac output equals stroke volume times heart rate. So, in a healthy person, you can either, if you need to get a higher output, they don't always have to increase rate and stroke volume. They can just increase one, and the other is going to collaborate with it, and it's going to increase your cardiac output. In most cases, though, both heart rate and stroke volume are going to go up because when you run or you're doing strenuous exercise, it's going to increase. Now, there are medications that we're going to talk about that can increase cardiac output by just increasing stroke volume. So how is the heart going to increase stroke volume without increasing heart rate? That's where Frank Starlin's going to have to come back in, right? We're going to have to give an inotropic medication that is going to make the heart have a more forceful contraction, which in turn is going to increase the workload on the heart, but it's going to make the heart have a more forceful contraction. So we're not speeding the heart up, we're just making more blood come out, all right? On the flip side, there may be medications that we're going to give that's just going to work by increasing the heart rate only, and by increasing the heart rate, we're going to increase our stroke volume. Example of that is atropine. We're going to give atropine for a bradycardic rhythm. They don't have good cardiac output because their heart is pumping too slow. So by increasing the heart rate, we're going to be pumping more, which in turn is going to increase stroke volume. And by increasing stroke volume and heart rate, we're going to increase cardiac output. Have I went down a trail? Have I confused you to the point to where it's like I'm about to go nuts? Because all this stuff really should be reviewed for you. And that's just what I explained there. Going back to preload, it's influenced by the blood volume returned to the heart. More blood is returned when more oxygen is demanded, because we're going to have more blood to be oxygenated in the lungs. So we're going to try to increase preload so that we can, in turn, increase cardiac output. Does that make sense? We want to the body's going to shunt more blood to the heart so that the heart can get more blood out to the body. What is a compensation mechanism that the body would do that, to try to increase? All right. So is vasodilation, is that going to get more blood to the heart? Vasoconstriction. So the body will vasoconstrict, all by the autonomic nervous system. It's going to vasoconstrict, which is going to force the pressure of the blood back to the heart. All right. And so again, old Frank shows up, and we're going to stretch, and we're going to get more out by adding more fluid to the heart. So if we have a constant stroke volume, cardiac output can be increased by increasing the number of contractions per minute. So there's going to be three terms that I might have told you, but it's dromotropic, inotropic, and chronotropic. Okay? So we're talking about increasing the number of contractions per minute, and this is going to be chronotropic. I like to think of chronotropic having to do with time, having to do with numbers. I'm increasing the rate, I'm increasing the time that the heart's beating. All right? Chronological, chronotropic. All right? So chronotropic is going to have to do with rate of the heart. And we got some more slides that explain this a little bit more. Inotropic, just a minute ago I was talking about increasing stroke volume by increasing stretch, and that's going to be a positive inotropic effect. So what do you think inotropic is going to have to do with? Contractility. And then dromotropic is going to have to do with velocity. And we'll get to that in just a minute. Here's that old sneaky preload back again. So do know that you will hear this for the rest of the time you're in medic school. You'll hear preload, afterload, inotropic, chronotropic, dromotropic. You'll hear all this stuff. Okay? Then you get on the ambulance and probably won't hear it again for a while. At least until you do a paramedic refresher or something. Preload can also be called end-diastolic volume. Alright, so if you see that on a test, you'll see, you may see it as end-diastolic volume. And I really think that I've already explained this. But let me just read this little part to you. Commonly called end-diastolic pressure. Preload is the pressure in the ventricles at the end of diastole. Okay? So that's the amount of fluid that's in the ventricles at the end of diastole. So that's the amount of fluid that the ventricles are going to have to start to work with the next round. Alright? Directly affected by the exact volume of blood that returns to the right atrium and may be decreased or increased based on the returning volume. Okay? So the way that preload, the way that you intertwine the amount of blood that's being returned to the body and the end-diastolic volume, as both of them meaning preload, is just the fact that the amount of blood, the amount of end-diastolic pressure, the amount of blood that's left in the ventricle is going to be directly proportional to the amount of blood that's coming back to the heart. Okay? So if you've got a lower amount of blood coming back to the heart, then you're going to have a lower amount of end-diastolic pressure, which means you're not going to have as much blood to work with for cardiac output. Okay? Am I on the moon, or am I still in the classroom with you guys? Alright. Don't be too prideful and tell me. So Starling's Law, I think you guys got a pretty good concept of that. You know, the greater the stretch, the greater the force. So this is just a depiction of preload. So the higher the amount of preload at the end of diastole, the higher amount of pressure that's in the ventricle, or the higher amount of fluid that's in the ventricle at the end of diastole, means the greater amount of fluid that's coming out. The more fluid you got, the more it's going to come out, right? Unless you've got a problem with contractility. And then it may just kind of hang out in the ventricle because the heart can't force it out. Isn't the heart cool? Just makes me so excited. Who needs a break? Okay. What time is it?
10:20.
10:22. Be back at 10:30. Alright, so just a little discussion going back, just to recap. Somebody explain to me in your own words how a balloon will reflect Starling's law and will reflect the myocardial cells.
The bigger the stretch, the more force that comes out, the more
Yeah.
you put into it.
Pretty much think of the myocardial cells with myocytes as elastic cells that have that stretchability, that contractibility, just like a balloon does. And the more force is that is exerted on the walls of the balloon or the heart, the more force it's going to contract down. Okay? With preload, the most important feature with the preload is going to be the heart's ability to handle the preload. Alright? So it really all starts with the preload and as far as what cardiac output is going to be. Okay? So what is the heart going to do intrinsically or naturally to a decreased preload to get more cardiac output out? What's it going to do?
Raise the heart.
It's going to raise the heart rate. Alright? So if it has less volume coming to the heart, it's going to start pumping faster to try to get more to it, right? On the flip side, in a natural heart, or a healthy heart, not a natural heart, a healthy heart, if it has a higher amount of preload, it may adjust its rate down a little bit so that it can allow Starling's law to take effect, slow the heart rate down, allow for a greater ventricular filling, allow for a greater stretch. Alright? Because if the heart rate is sped up, that's one of the problems with tachycardic rhythms, is the fact that Frank Starling can't play. Because the myocytes don't have time to stretch out because they're going so fast, they don't have time to stretch out, and they don't have time to force that amount, that ejection fraction out. Does that make sense? Changes in arterial pressure have minimal effect on cardiac output because the changes in the pressure itself isn't going to affect cardiac output as far as preload goes. The amount of blood returning back to the heart is going to affect preload. Alright? So, an example of this would be like in dehydration or hypovolemia. The vessels themselves may increase in pressure because they're trying to get more blood back to the heart. But that increase in pressure really isn't going to directly affect the heart. The amount of fluid that increase in pressure is getting back to the heart is what's going to affect it. Okay? Does that make sense? Okay. I need to start carrying my clicker, don't I? So the heart has the adaptability to pump however much blood the body tells it it needs. Alright? So with the amount of blood that the heart's pumping to the body, this is a good example of systems working together. Alright? So when we think about the heart working, what is the major system we usually think about the cardiac system working with? The pulmonary system, right? Cardiopulmonary, right? But what really controls a lot of the aspects of rate and the amount of blood getting to the rest of the body, what really tells the heart how it should act? What? The nervous system. The sympathetic nervous system, or the autonomic nervous system, which in turn the sympathetic and the parasympathetic both have big parts in it. I think I've hit this in the ground. Venous return is the most important aspect of stroke volume. Because if you don't have blood back to the heart, you don't have blood to pump out of the heart. I mean, it's that simple. Okay? Preload is going to directly affect afterload in the fact that if it doesn't have a lot of blood to come in, it doesn't have a lot of cardiac output to go out. It doesn't have a lot of blood to go out. Okay? I think we need to move on past this. Alright. We're going to revisit the basic electrical conduction system of the heart. It may be crazy loud.
This animation explains how a cardiac cycle is in the heart. The cardiac cycle starts when an electrical impulse or action potential is generated by the sinoatrial node. The electrical impulse travels along specialized conducting fibers in the walls of the atria, stimulating the atria to contract and pump blood into the ventricles. In the normal heart, impulse travels very rapidly. As a result, all the muscle cells in the atria contract together, producing a coordinated pumping action. The impulse also travels across the right atrium to the atrioventricular node, where it is delayed slightly to allow the ventricles to relax and fill with blood before they contract. The impulse travels along the bundle of His, where the conducting pathways divide in two, forming the left and right bundle branches, which lie in the interventricular septum. From the bundle branches, the impulse spreads into the inner walls of the ventricles via specialized conducting fibers, called Purkinje fibers. Finally, the impulse travels up the outer walls of the ventricles towards the atria. The rapid and controlled spread of the electrical impulse through the ventricles stimulates the muscle cells in the ventricles to contract together and pump blood efficiently to the lungs and body. As you will see, during atrial fibrillation, the electrical activity of the atria becomes disorganized. As a result, the pumping function of the atria is lost, and the rhythm and efficiency of the entire heart are disturbed.
So that last part about the AFib, that's kind of getting the horse ahead of the wagon, but we're going to talk about that in the future. So just revisiting this, cardiac cells have four properties: excitability, conductivity, automaticity, and contractibility. Excitability is what allows the response. It allows the stimulus. It's really what gets the process of depolarization going. Alright? Depolarization is going to be contraction. Conductivity is really the power line system of the heart. Each cell has the ability to pass that electrical system or that electrical charge on down. Alright? So it can start in the dominant pacemaker and make its way all the way down by that property. Automaticity is the one that can get the heart into trouble sometimes. Because automaticity means that any myocardial cell has the ability to generate its own electrical impulse without stimulation. Alright? It means it just has the ability to just all of a sudden create a charge. And then contractility is the ability to contract. You need contractility when you get that depolarization, alright, because when it gets that electrical impulse, it needs the ability to contract to receive that impulse. Okay? In order for this to work, you've got to have the specialized conduction tissue which propagates the electrical impulses to the muscular tissue. So remember, I was talking about you've got the electrical system of the heart, and then you've got the mechanical function of the heart. So this specialized tissue is what's going to be the liaison between the two. It's what's going to take the electrical impulse that's generated and put it off on the mechanical aspect of the heart, the worker cells of the heart, to allow them to contract. Okay? The pacemaker, whether it's the SA node or the AV node or a ectopic cell, is what sets the rate for cardiac contraction. What's the dominant pacemaker? The SA node. So is the SA node one cardiac cell, or is it a bunch together to form a node?
Bunch together.
Yes, bunched together. All right. So the SA node is going to be located in the right atrium. Now, the heart, when it pumps, does the right side pump and then the left side pump? Does the top pump and then the bottom pump? That's what happens. So both atria are going to contract and both ventricles are going to contract. Alright? So both pumps are pumping at the same time, except one's pumping to the lungs and one's pumping to the body. Make sense? Yes. Alright. So the SA node is going to be at the right atria. Alright? It's going to be right here. We're going to understand next week the importance of the location of these nodes when we look at the actual electrical activity. But the SA node has these internodal pathways, which is really just the power lines to transmit the electrical impulse to the atria. Alright, so if the SA node is just on the right atria, something's got to stimulate the left atria. Alright, so you've got these internodal pathways that bifurcate into this Bachmann bundle, which is a big node that kind of wraps around the left atria, which stimulates it to contract. Alright? So once it contracts, that impulse is going to continue on into the AV node. So the AV node would be your secondary pacemaker. Going back to the SA node, what is the intrinsic rate of the SA node? The normal rate. 60 to 100. So coming to the AV node. 40 to 60. Okay? High end being 60, hardly ever will you have a... These are going to be called junctional rhythms because they're at the AV junction. These are created by the AV node. Hardly will you ever see a junctional rhythm in the 60s. Okay? At the AV node, it slows the impulse by milliseconds, but it slows it down before it reaches the ventricles. Why?
To give them time to fill.
Yeah, to allow for ventricular filling, to allow that atrial kick to go in and to allow that last bit of, 30-40% of blood to enter the ventricles. And then once the ventricles have filled, it hits this big nervous bundle here called the bundle of His, or the bundle of His. Okay? And so this is going to go down through the intraventricular septum. So what's going to happen after that is that the bundle of His is going to bifurcate off, bifurcate means to split, off into two different bundle branches, which are still bundles of nervous myocardial tissue that's continuing to transmit the electrical impulse. So you're going to go to the right side, and so the right bundle branch is going to be responsible for what? The right ventricle, or the right bottom part of the heart, and the left side is going to go to the left ventricle. So then, the bundle branch then further bifurcates off or branches off into these Purkinje fibers, which in turn are still just bundle branches. They're still nervous branches that are going to wrap around the backside and the rest of the heart. We talked about that. A couple of these terms, the James fibers are in the intermodal or the internodal pathways, those electrical lines. The Mayheim fibers extend into the ventricles. And then the bundle of Kent enables early depolarization of ventricular tissue. We don't really want the bundle of Kent nerve cells to really be doing anything because we don't want early depolarization of the ventricles. Alright? Depolarization, contraction. Repolarization, relaxation. Alright? So we don't want early contraction of the ventricles because that's where your PVCs and even your lethal ventricular rhythms could eventually come from. With the SA node, if the atrial rate becomes rapid, not all of the impulses go through the AV junction. Alright, so that picture was just a depiction of the most basic nerve pathway. But you got to remember, the heart has tons of nerve pathways that under normal conditions is going to follow the SA track. Alright? But if it becomes too rapid, then it may pass on past the AV junction into the bundle of His, into the right and left bundle, and into the Purkinje fibers. So it may totally bypass that AV junction and go on into the ventricles. The dromotropic effect is the effect on the conduction velocity, okay? So that's going to be the force of the electrical impulse, how quick it's going through, all right? And so if it goes too fast, if the dromotropic effect goes too fast for the heart to keep up, then it's going to start finding what they call aberrant pathways, which are just pathways that are not the normal track, and then they're going to start having re-entry beats, which means that they're going to follow a different pathway, and then they're going to re-enter the ventricles in areas that they normally are not supposed to. So you start having myocardial cells start doing their own thing, then you start having a lot of issues. Okay? Depolarization is what I just told you. Muscle fibers are stimulated to contract. The way that this happens is through concentrations of electrolytes across cell membranes. The myocardial cells become bathed in electrolyte solutions, and the chemical pumps maintain ion concentrations. We've got another part of this lecture that we've got to do to understand that more. But what do you think your primary electrolytes are? Sodium, potassium, and calcium. Magnesium's going to play a part too, all right? But your primary ones are going to be sodium, potassium, and calcium. So remember in advanced EMT talking about the sodium-potassium pump? This is where it's going to make more sense because we're going to really see it on the heart. Because it's very important in the heart. So remember, the cell has a semi-permeable membrane. I always kind of relate it to like a spaghetti strainer, right? Spaghetti strainer will allow fluid to pass through, but the big spaghetti noodles or the big particles, it's not going to allow it to pass through that filter, right? So in order for that filter to allow itself to pass through, it's got to have these gates on it, these protein gates, these protein channels. Sodium-potassium pump is a protein channel that's going to allow for sodium to come in and potassium to come out of the cell. So in a normal resting state of a cardiac cell, let's see if I can figure this out. I better not get to. Something's telling me not to mess with it. Me and the smart board are not real good friends. Okay. But since I'm recording this, I want to put it on here. So imagine this is a cardiac cell, okay? In a normal resting state, what's going to be the primary electrolyte inside of the cell? What's going to be the primary electrolyte on the outside of the cell? All right. So in order for depolarization to occur, what has to happen to the polarity or the charge of the inside of the cell? It has a cross concentration gradient and the charge has to become higher, right? So relative to the outside of the cell, the extracellular area, in a resting state, the inside of the cell is negative. compared to the sodium on the outside, the potassium in the inside of the cell is negative. So what has to happen to the inside of the cell for us to make it positive? So the sodium potassium pump has to activate, which is an active transport, right? Which means it requires energy. So the potassium has to, the potassium has to go out, and then the sodium has to go in. All right, and so this is going to be in your action potential. Okay, so that's the first part. This is what's you're going to have a rapid influx of sodium, which is going to make the inside of the cell positive. And so it's going to start the depolarization process. So, and we're going to talk about phases here in a few minutes, but so in order to get a full contraction of the cell, at that point, you have to start having calcium come in as well. Okay? So the calcium is what's really going to force the contraction. All right? So the influx of sodium into the cell, the outflow of potassium out of the cell, is what's going to engage the depolarization process. All right? So depolarization in itself isn't going to make it contract unless you get the calcium in, which is going to work on the myocardial cells, and it's going to make the contraction. Okay? And I'm going to show you some of those slides here in just a few minutes to further show you what I mean. Do what? It is not a negative ion, but compared to the polarity of the sodium across the gradient on the outside, it's more negative than sodium is. Alright, that's the best way I can answer it. Do what? What?
I was asking why was cells like negative?
Right, right. And it's all relative to the outside, alright? And yeah, and I've got a little bit better picture here in just a minute. Alright. So that is all part of active transport. This little chart right here, I'm going to show you a little bit more here in just a few minutes. Alright. So a couple of other terms. Absolute refractory and relative refractory. The absolute refractory period is the time when the cardiac cell is completely depolarized. Alright? And so that means that an action potential cannot act on that cell. Alright? It cannot have energy work on that cell at that point. Alright? It is completely at rest. There's nothing that can stimulate that cell. It's a very short time. Okay? The relative refractory period means that it's not completely repolarized yet. It's not completely at its resting state. But if it's acted upon by an outside force, by a stimulus, it's going to contract. This is where you're going to get R on T phenomenon. And you'll hear this in the future. Basically what this is that you've got two phases of the depolarization process happening at the same time. You've got the cell is trying to relax, but at the same time it's trying to start depolarizing again. I know that's confusing as crap, but that's a bad thing. So the way that you can think about action potential, think about this for a minute. You're not expecting this. You just used the toilet. You are a clean person, so you flushed the toilet. Right after you flush the toilet, if you jiggle that handle, will anything happen? Right after you flush the toilet, will it allow anything to happen? No. But if you wait for a little while longer, even though the bowl's not completely full again, if you jiggle the handle, what's going to happen? It's going to have a much weaker flush, but it's still going to do something, right? So that's kind of the way the action potential works with the absolute refractory period and the relative refractory period. The absolute refractory period, the cardiac cell just flushed itself and nothing can act on it. The relative refractory period is going to be stuff can act on it, but it's not going to be the full potential of what the cell can do. I know this is kind of throwing you out there. This isn't review, this is new stuff, but you're going to see it a little bit better in just a minute. Alright, so your secondary pacemakers, we've talked about that. Measuring the heart's electrical conduction activity. We're going to quickly go through this. The P wave is a representation of the SA node. It's representing atrial depolarization. Alright, you're not going to hear me say relaxation and contraction anymore. We're going to use the terms depolarization and repolarization because we're talking about polar opposites, we're talking about electrical charges, we're talking about the heart. So it's depolarization and repolarization. So the P wave is atrial repolarization. The P wave is indication of the SA node has fired and the electrical charge has went down the internodal pathways and the atria has contracted. The PR interval is from the start of the P to the start of the R wave, which is going to be here because you're going to have your Q wave here. Alright? And we're going to talk about that because the PR interval is going to give us an indication of a delay in SA node conduction. Alright, so if the PR interval is longer, that's going to say, hey, it's taking longer for the electrical conduction to go through the atria, which may not be a good thing. Alright, so then you've got your QRS complex, which is indication of ventricular depolarization. Why don't we see atrial repolarization on this wave? It's covered up by the QRS. It's a lot weaker than the QRS, the amplitude of the QRS. Alright? Then you've got the ST segment. The ST segment is going to be the portion of time between the S and the T wave. What do we look at the ST segment for? Remember elevation, depression? What do we look at that for?
Signs of a heart attack.
Yeah, MI. ST elevation is going to show us that we've got injured ventricular cells that it's taking longer for that contraction to go through. Once a myocardial cell becomes oxygen deprived and ischemic, it's not going to depolarize the way the rest of the healthy cells are going to do. So that's going to give us a good indication that it's taking a minute for this electrical activity to either go through this injured cell or it's totally bypassing. Okay? Then you got your T wave, which is going to be your ventricular repolarization. And the reason why we see the T wave is because there's nothing else occurring in the heart at that time. Okay? So to put the refractory periods that we just talked about, all that mumbo jumbo about the toilets and all that stuff and flushing and all that, your refractory periods are going to fall. So your absolute refractory periods are going to fall somewhere around this part, really somewhere around this part of the QRS to the ST segment, okay? So in this area right here, no stimulus. Alright? This is your absolute. So if an electrical stimulus tried to act on that myocardial cell at this time, if it's in this phase, which again is a very short phase, nothing's going to happen. But from this phase until here, this is your relative. So that means that a stimulus, a charge, can hit here, all right? And so while the cell is trying to recover, while the QRS, while the ventricles are trying to repolarize or trying to rest, a new electrical charge is trying to fire. So what's going to happen is you're going to have atrial depolarization falling under here. Then you're going to start having the QRS, and what's going to happen is you're going to have ventricular depolarization happening at the same time that you've got ventricular repolarization. Oh my God. What are you talking about? All it is somebody's trying to get, well, all it is electrical charge is trying to make the ventriculars contract before they're ready to, before they fully rest. Okay? What?
Absolute was the what number? Repeat that. Sorry.
Absolute is going to be like in the QRS complex and all that, and then you're going to go from your S to your T as a relative. I've got some more charts in just a minute. This isn't nowhere near as fun as advanced EMT, is it? Y'all feel smarter already? I just feel tired. I just went through all that. We're going to see this video later on. Alright, the autonomic nervous system, we've already talked about. It has control. This is where, remember in advanced EMT, you talked about the alpha and beta cells and the adrenergic receptors and all that. This is where we're getting deeper into that. So, the sympathetic nervous system is going to be the primary action on the heart, whereas the parasympathetic is going to be stimulated by the vagus nerve and all that, and it's going to help slow the heart down. Again, sympathetic speeds everything up. Parasympathetic restores the vegetative function, slows everything down. You can go back and look at that chart. Couple of terms that you've seen before, maybe not dopaminergic, but adrenergic and cholinergic. All right, cholinergic is going to be with your parasympathetic nervous system. Okay, adrenergic is going to be with your sympathetic nervous system. Okay, cholinergic. Cholinergic. What medication would you give that is a anticholinergic? Huh? Atropine. Atropine is an anticholinergic. All right. And then this dopaminergic is going to have some regulation with the renal glands and the kidneys and things like that. The sympathetic nervous system is going to have a lot to do with your vasoconstriction and your bronchodilation, whereas the parasympathetic is going to be a lot of your body's vegetative functions, your rest and digest. It's going to also have to do with your GI. The vagus nerve is a nerve of the parasympathetic nervous system. When we do a Valsalva maneuver, or vagal maneuver, we're trying to stimulate the vagal nerve, which in turn is going to stimulate the parasympathetic nervous system, and the parasympathetic nervous system slows everything down. So that's why that's always a first line in a stable tachycardic patient, is try to get them to bear down. If the brain senses the heart should slow its pace, the parasympathetic nervous system is going to engage where it's going to go to the SA node. Acetylcholine, ACH, is the primary chemical mediator of the parasympathetic nervous system. So if the parasympathetic nervous system engages the heart, it's going to release acetylcholine. This signals the heart to slow down, and then more acetylcholine is going to go to the AV node to tell the AV node, hey, we're slowing down, don't try to pick up, don't try to pace the heart. We got this, we're good. The sympathetic, what is the primary chemical mediator of the sympathetic nervous system? Huh? Epinephrine, adrenaline. Remember fight or flight? Adrenaline? And it's really where your adaptive responses are going to be. So the sympathetic nervous system, the way that it's engaged is that the chemical, what are those? The chemoreceptors in the body are what is going to activate the sympathetic nervous system. They're going to tell the brain, hey, we're getting low on oxygen. You need to speed the heart up so that it will start going faster and will increase cardiac output. Because that's the body's response, the heart's response to low oxygen is to increase cardiac output, right? This also, the heart speeds up to prevent lactic acid buildup. This goes way back to like the second or third lecture in advanced EMT, anatomy and physiology, or pathophysiology. The heart, or the body does without oxygen, the cells are starved of oxygen. What's created? Eventually lactic acid, right? So the heart's going to speed up to increase cardiac output so that we don't have that lactic acid buildup, because what happens when lactic acid builds up in the body? We become acidic, right? We go into acidosis. I've already told you about the chronotropic, dromotropic, and inotropic. You'll hear these again in Brandy's class. You'll hear these again in this class. Alright? Because a lot of your medications are going to be specifically chronotropic, meaning they're going to increase the heart rate, or dromotropic, which they're going to increase the electrical conduction of the heart, or they're going to be inotropic, which means they're going to act on the contractility of the heart. Make sense? I'm not going to spend a lot of time on this, but drugs that act on the sympathetic nervous system, they're either going to stimulate the alpha receptors or the beta receptors, right? You got your alpha 1, your beta 1, and your alpha 2 and your beta 2 receptors. Remember, most of the medications that you learned about in advanced EMT, well, a good bit of them were all sympathetic agonists, right? Epinephrine, albuterol. You know, a lot of those medications, I said most of them, there's only a couple of them, but a lot of those medications stimulate the nervous system, the sympathetic nervous system. When we talk about the heart in the most general sense, with the adrenergic receptors, we're going to, in the most general sense, we're going to think alpha constricts and beta dilates. Alright? For the heart. For the heart. Because remember, like beta 2 receptors, receptors in the sympathetic nervous system have no effect on the heart, but beta 1 does. Beta 2, what does beta 2 receptors do in the body? What? Albuterol is a beta 2 sympathomimetic. Bronchodilates and vasoconstricts, right? Has no effect on the heart. But beta 1 is going to have a little bit of effect of the heart. We'll get to those drugs in just a minute. So here's kind of a weird picture, and there's several weird pictures. You'll see them in your book too. So the heart, beta 1, works on the heart. Beta 2 works on the lungs. Beta 1 and beta 2 work on the arteries. What's the role of the sympathetic nervous system of the arteries? To vasodilate or vasoconstrict, right? I promise it's going to get a lot more fun in here. We're going to do a lot more funner things. So hang in there, bud. I know. Then your alpha receptor is going to work on your lungs. So these drugs that affect the sympathetic nervous system, they're going to be chemically made to where they fit lock and key into these receptors, right? Just like some of the drugs that we talked about, they fit into the receptors to either further increase, I'll get you in just a minute, to either further increase the sympathetic stimulation or to block the sympathetic stimulation. Okay? Yeah?
What's the chemical difference between beta 1 and beta 2 and alpha 1 and alpha 2?
I don't know. I mean, I don't really quite know what you're asking as far as like.
How does your body know what the difference is? Like, is it a different receptor?
Yeah, they're going to be. Well, you know, I don't really know as far as the beta 1 and the beta 2, but now it will have a different receptor site for the alpha and the beta. So it would know if it's an alpha receptor site by its shape or the beta, and it may be, you know, just the terms of the different shape of it, for a lack of a better word, and how the receptor site is shaped. I don't know like any other explanation than that. And really and truly, we don't really have to get that deep into it. Remember this term, sympathomimetic? It just mimics the effects of the nervous system, sympathetic nervous system, on the heart. A sympathomimetic is going to increase rate, increase force, increase automaticity. Remember, the sympathetic nervous system increases everything, except on the lungs, it's going to bronchodilate, but it's going to have to find that receptor in order for it to work. So a drug that is a pure beta agent is isoproterenol. Talk about that in a little bit. Phenylephrine, also known as neosynephrine, is a pure alpha agent, and really it's not going to work on the heart at all. Phenylephrine is going to really be just for vasoconstriction. Alright? You'll learn about pressors, alright, which are medications that we give to vasoconstrict to increase blood pressure, are pretty dangerous drugs. Neosynephrine is one of them. Alright? Neosynephrine is also what you shoot up your nose when you have a runny nose and nose spray, because it makes those vessels constrict, and it makes, I guess, the sinuses constrict down too. Go back and really look at this stuff. Your beta 1 is really your cardiac, your beta 2 is pulmonary. I've already said that. Then you got the cool mustache guy who is the beta blocker. So if a beta stimulator or a beta sympathomimetic increases heart rate, it mimics the nervous system, what's the beta blocker going to do? It's going to decrease blood pressure and decrease heart rate. Your blood pressure, your common blood pressure, your common beta blockers are going to have the suffix LOL, L-O-L. Propranolol, Inderol, well, that's propranolol. What?
Labetalol?
labetalol,
Metoprolol.
metoprolol, those are very common ones. So they're going to block the beta receptors. Okay. Atropine is a parasympathetic blocker. Remember, it's an anticholinergic, so it goes against the cholinergic properties. Norepinephrine is a sympathetic, and iso is a sympathetic too. Again, I'm not going to spend a lot of time. Just come back and look at these medications. Blood pressure is going to be influenced by your cardiac output. The more cardiac output, your higher blood pressure, the greater your systemic vascular resistance. All right. So that's the end of this first lecture.